All right, we'll go ahead and get started. Welcome, everyone. My name is Crystal Price, and I'm the Associate Director of Registry Programs here at the PCPI, and welcome to our measure testing webinar. Today, we're going to cover measure testing and registries with a couple of case studies. So this is our agenda for today. I'm going to go through some welcome and housekeeping items. We'll go through introductions and then the presentation of our case studies. After that, we'll have a discussion, and if you have questions, please put them in the chat window at any time during the presentation, and then we will take those questions for a discussion after we've done both presentations. After that, we will close out with On the Horizon. And you have to forgive my companion, my workmate here who's joining me this afternoon. This forum is being recorded. All of your lines are muted. And again, please put your questions in the chat box, and we will respond to those as the webinar goes on. With that, I'm going to hand things over to Samantha Tierney, who is our Senior Director of Measurement Science here at PCPI. Sam?
Thanks, Crystal, and thanks to all of you for joining us. I'm very pleased to introduce the esteemed speakers we have with us today to share their experiences testing measures within their own QCDRs. First up, we'll have Dr. Mark Antman, who is currently the Senior Manager of Quality Metrics and Initiatives at the Society of Thoracic Surgeons. In this role, Mark is responsible for maintaining NQF endorsement for the Society's portfolio of 30-plus quality metrics, ongoing measure development activities, public reporting of surgical outcomes data, and other quality initiatives. Prior to his work at STS, Dr. Antman provided healthcare quality consulting services, served as Director of Measure Development Operations for the AMA and the PCPI, where I had the pleasure of working for him, and began his career in the practice of general dentistry. The next up, we'll have two speakers from the American College of Rheumatology. We'll have Rachel, and please, Rachel, correct me if I say your name wrong, Myslinski, who has 16 years of experience in the healthcare industry, primarily in the Professional Medical Association, the Management Consulting, and Nonprofit Research Foundations. She is the Vice President of Practice, Advocacy, and Quality at ACR and leads the ACR's Practice, Advocacy, and Quality Department and oversees the ACR's Rise Registry, which is a QCDR for rheumatologists. We'll also have Tracy Johansson, who has been a member of the Rise team since March 2016. She was introduced to the field of rheumatology through her previous role with the Rheumatology Research Foundation. Tracy's primary responsibilities include managing the ACR suite of rheumatology quality measures and their implementation in RISE, as well as overseeing the use of RISE for research. So without further ado, I'll turn it over to Mark to begin his presentation. Thank you.
Thanks very much, Sam, and my thanks to Sam and Crystal and the PCPI in general for inviting me to be to present on this webinar. It's a pleasure to reconnect with some of my old PCPI colleagues, and glad I have the opportunity to present to all of you. So next slide, please. So quick overview. I'm going to provide a little bit of background information on STS registries and our measures. I'll give you a little bit of background on the CMS guidance on measure testing, which many, or if not most of you, may be already familiar with. I'll go through some examples of what the STS does in our measure testing, split out by three different types of measures, as you see here. We'll talk a little bit about some challenges in measure testing, and we'll touch on lessons learned and best practices. Next slide, please. So by way of background on the STS National Database began over 30 years ago, as you see here, with our adult cardiac surgery database. In 30 plus years of operation, the adult cardiac surgery database has over 6 million procedure records. There are close to 4,000 participating surgeons and anesthesiologists now. STS also has several additional registries, our congenital heart surgery database, our general thoracic surgery database, and most recently in the last couple of years, we've added the Intermax and Pedamax registries. These are registries for outcomes for patients with, excuse me, as you see here, mechanical circulatory support devices. STS, the STS database has been a QCDR, Qualified Clinical Data Registry, for MIPS reporting. We are certainly in 2020 and have been for as long as the MIPS program has been in existence. And before that, frankly, STS was using our registry to send data to CMS on behalf of our surgeons for the CMS programs that preceded MIPS, of course, which many of you are probably familiar with, PQRI, PQRS, which of course evolved into the current MIPS. STS has 35 NQF endorsed measures. You see the distribution here. And as you can see, the majority of them are outcome measures for the various cardiothoracic procedures that our surgeons perform. These are generally separate measures for surgical mortality and surgical morbidity. There are several instances in which we have combined mortality and morbidity into composites. There are 6 instances of that. For the most part, those composites are just outcomes only, morbidity and mortality, as I said. We do have one instance in which we have a composite that covers not only outcomes, but some process measures as well. Next slide, please. So again, many, if not most of you are familiar with CMS guidance on measure testing. Let's just do a quick review here in case you've not seen these statements. Most importantly, from the final rule, from the 2020 final rule for the QPP, QCDR measures must be fully developed with completed testing results at the clinician level and must be ready for implementation at the time of self-nomination. Now, I recognize that that means that some of you may be putting testing protocols in place for the first time, and some of you may be simply moving testing earlier in your measure development process. But in either case, I hope that the information that I'm sharing with you today, and that, of course, my colleagues at ACR are sharing as well, I'm hoping this will be helpful for you in your testing efforts. Next slide, please. So let's go into a little bit more detail, some more specifics on what CMS is looking for measure testing. You see on the slide here, this is taken from the 2020 Call for Measures fact sheet. They're specifying, again, hopefully you've all seen this. They're giving more detail. They've given more detail on what they mean by reliability testing, validity testing, and feasibility testing. Now, it's notable at the top, reference is given to measures endorsed by the NQF, as I think you all know. And I'll say that much of the rest of my presentation is focused on what STS does specifically for measure testing for our NQF submission. We submit our NQF testing to CMS during the measure self-nomination process. If necessary, we put it on the CMS web forms, and CMS accepts the NQF testing data. So obviously, it's a clear advantage to have done NQF testing beforehand. Now, just a quick review of reliability and validity. Again, this may be unneeded for many of you, but reliability is basically an assessment of the consistency with which a measure can distinguish performance between providers or over time. So as you see here, it may be signal to noise analysis. It could be inter-rater reliability. I should note here that I am not a statistician, and so I can't provide you with more. I could certainly show you the signal to noise analyses that we do at STS, but I can't further explain our signal to noise analyses. But I hope you're familiar with these methodologies, and of course, PCPI staff, I'm sure, can help you with these testing techniques if that's needed. Validity, just again for a review, validity basically assesses the degree to which you're measuring the information, the degree to which you're actually measuring the information that you intended to measure, right? So validity can be demonstrated by, as you see here, correlation of data element or the measure score with a gold standard. And in some instances, that can be the CAPI agreement between the data element extracted via the EHR and chart abstract. And then there's also a definition here of feasibility. Feasibility is the least challenging of these, and so I'm not going to talk much more about that. I will describe what STS does for feasibility testing, however. Next slide, please. So a few examples, as I said, separated out by 3 different categories of STS measures. I'm starting here with an outcome measure, which, as I said, these are the majority of STS measures. The specific measure is listed here, but it's not, it's what it is. The outcome measure that I'm using as an example, of course, is not critical. For reliability, we do signal-to-noise analysis. For validity, as you see here, we do re-abstraction of selected variables, including all critical data elements from the medical records, in comparison to submitted data. To clarify, STS routinely does an annual audit of 10% of our surgical programs. That's something we do whether we are submitting to NQF or not, but that audit data is very helpful for us and does actually meet NQF criteria for validity. So that is what we send to NQF, and of course we then pass it on to CMS as well. And I'll actually in a moment or two I'll show you an example of a data accuracy table that we get from our audit data, which may hopefully be helpful to you to see as an example. For feasibility, and this will be the extent to which I talk about feasibility. In our experience, in STS experience, as long as you can document that the data elements are generated as a byproduct of care processes, and that all the data elements are submitted from practice sites to your database or your registry in electronic format, and much of that language is taken from the NQF testing form. As long as you can demonstrate those requirements, that is satisfactory for NQF, and I know from our experience that that's satisfactory for CMS as well. Okay, next slide, please. So my second example is for a process measure. So here, in the case of this process measure, again, it happens to be anti-lipid treatment at discharge, but this is the case for many of our process measures, if not most of them, as well as some of our other measures. In this case, and for many of our measures, we take advantage of an NQF provision that states, as you see at the bottom of the slide, if accuracy or correctness or validity of the data elements was empirically tested, separate reliability testing of data elements is not required. Now, again, whenever we've submitted our NQF testing data to CMS for our QCDR measures, it has been accepted. They have deemed it acceptable. I don't know specifically if CMS has commented or will comment on this allowance, if you will, to not provide anything specific to reliability testing, but rather to defer to critical data element testing for validity. Given that NQF allows for that, I can't speak to whether or not CMS will accept that. I anticipate that they will, because as I said, if it has been acceptable to NQF, in our experience, it has been acceptable to CMS as well. For validity and feasibility here, these are the same. Our methods are the same as I illustrated for the outcome measure that I started with. And next slide, please. So my third and final example is for a composite measure. Again, this may not be relevant to many of you, but if you do have composite measures, and if you are using them in your QCDR for MIPS, NQF does require for composite measures that validity testing has to be done at the level of the composite measure score. So in this instance, we do demonstrate validity with predictive validity of the composite measure score. We use Pearson's correlation and Spearman's correlation. Again, I'm afraid I can't explain those further to you, but if you want to email me after this webinar, I can give you more detail on those if that's of interest to you. And again, feasibility is as described previously. Next slide, please. So I said a moment ago, with respect to validity, in my first example, This is an example of the data accuracy table just an excerpt, a small excerpt rather, from the data accuracy table that we sent to NQF. And again, these are data that are pulled from our annual audit, our 10% annual audit of all of our practice sites. It's the same data we wind up sending to CMS, and it's acceptable to CMS. And as you can see, for us, data accuracy really requires documenting certainly data accuracy, but also data completeness. And as you can see here, well, you can read along with me in the fine print beneath the table. Data accuracy, the completeness rate displays the percent agreement rate for each data element that was submitted and not missing. That's the critical part. That that the data is not missing for any one of these variables. And data accuracy is the percent of correct responses submitted for each data variable. Now, what we have found is that, and you can see, don't try to do an average or a mean of the three variables listed here, because as I said, this is an excerpt from a much more extensive table. But our overall data accuracy for this measure from this audit was over 97%. I don't think that NQF has a specific cutoff for what they consider to be a good demonstration of validity, nor do I believe that CMS would have a cutoff for that. But as long as you demonstrate data completeness and data accuracy in the high 90s for your measures, I think that that certainly has been acceptable to NQF, and I anticipate that it will be for CMS as well. Next slide, please. So let's talk a little bit about challenges in measure testing. Certainly, you need to have some expertise in measure testing and data abstraction. Either you need to have that expertise in-house, or you need to contract for it. STS does contract for our measure testing services. Again, part of it is through our annual audit of practice sites, which is through one contractor. We do also have data analytics services, which are through another contractor. I recognize that we are fortunate that we have those relationships. Hopefully you have these, each of you has those capabilities either within your own shop, your own organization, or you have contracted for them. Certainly cost is a challenge. I can tell you that STS budgets very significantly for the services that I've described, and I'm sure you're all familiar that that is a very costly step in your measure implementation and your measure maintenance, and certainly for maintaining your measures in a QCDR. NQF testing criteria, although NQF testing criteria is very robust and very helpful, there are some instances in which I see it as a bit of a challenge. If we'll go to the next slide, please. Here's an example of the NQF algorithm for evaluating reliability. I recognize it's not possible to read this algorithm on this slide. And some of you may have seen this in NQF's documentation. It's very complicated, right? But to NQF's credit, I'm being a little humorous about NQF, but honestly, to their credit, they do provide excellent guidance throughout in their measure evaluation guidance. And it is possible to get a good understanding of what they mean by every type of testing if you follow their documentation. So enough said about that. I will say, however, that NQF has a similar algorithm to this one for validity as well. So don't be overwhelmed by their algorithms, but follow their recommendations in their text. And again, it is very helpful if you need guidance on how to do this different type of testing. Next slide, please. Some of you may have been on the NQF webinar earlier this week, where there was NQF staff did solicit some input on what challenges there may frankly be post-COVID. And one of the participants mentioned challenges with accessing medical records for data element level testing or for chart audit. Certainly that'll be a challenge after COVID. And there may be issues with the organization, the measure developer themselves, and for practice sites prioritizing testing requirements relative to safety concerns related to COVID. I think that I certainly would be, and I would imagine PCBI staff would be interested in other feedback that you have in our discussion portion of the webinar following these presentations. So I thought it might be helpful to touch on the unfortunate but the very real circumstances that we're all dealing with COVID. Next slide, please. And lastly, let's talk about a little bit about lessons learned and best practices. In my experience with, again, primarily with NQF submissions, the uniformity in testing timeframes is critical. In fact, we have been tripped up, if you will, on occasion with our NQF submissions, and I would imagine that this would be significant for CMS as well. If your testing timeframes are not consistent throughout your testing documentation, so I have experienced at least one instance with an NQF submission where, for example, we may have used a measurement period for a 3-year documentation for 2014 through 2016. But we used a slightly different 3-year time period for some other aspect of testing within the same submission. And NQF questioned that and said, you really need to be you need to be providing us with testing data that's consistent throughout. In other words, use the same testing timeframes for all of your testing. So again, if it's an issue for NQF, I would imagine that might be an issue for CMS as well. Specifications. You're probably all very aware that it's difficult to get reliable and valid testing results unless your specifications are current and, most importantly, very precise. Your ability to test accurately is entirely dependent on the precision of your specifications. Levels of analysis is maybe a moot point in this instance, since CMS is requiring that your measures be tested at a clinician level. I would just caution that as you do so, be sure that you're not conceivably mixing clinician level testing with group level testing, or perhaps if yours is a surgical based specialty, forgive me, a hospital based specialty, it's possible that you could be mixing in hospital level testing. So just be sure that you're consistently going with clinician level testing. And then lastly, again, this may not be relevant to any or many of you, but if you have composite measures in your QCDR, for MIPS reporting, STS, NQF does require that the individual component measures within a composite be tested individually, or forgive me, they have to be individually endorsed. So again, perhaps not relevant to you, but that does make it more challenging to be using a composite measure in your QCDR. Next slide, please. I think I will stop there. I apologize if I've gone over by a minute or two. Hopefully it wasn't more than that. I'm looking forward to Rachel's presentation and any questions that follow. So thanks very much.
Thanks, Mark.
Great, this is Rachel. Crystal, if you can go to the next slide. So I'm going to talk a little bit about how the American College of Rheumatology set up our measure testing program. And then really Tracy Johansson is going to talk in more detail about how we've kind of adapted our measure testing approach out of our QCDR registry in order to meet NQF requirements, but also do it in as efficient and effective way as possible. So next slide. So the ACR has one registry. It's called the Rise Registry. It's an EHR-enabled registry. We launched in 2014, and we are pulling data from over 1,000 rheumatologists across the country. We're pulling data directly from their EHRs, and we are incorporating all the clinical data from their EHR, as well as in some practices, their practice management or other systems, into the registry, and that is kind of the basis of our quality measure dashboard, our quality improvement activities, and kind of all of our measure testing work that we do with the registry. So those 1,000 providers represent about 35% of the practicing rheumatologists in the U.S. And we have over 2 million unique patients and over 17 million patient encounters in the registry. So next slide. And so as we launched our measure development program, which was probably 8 years ago now, we really set it up with a flow in order to meet what was NQF's requirements at the time. We as the ACR initially made the decision that all measures that we developed, we were going to put into the NQF program for endorsement. Since that time, we have stepped back from that position, but our approach has been kind of formed in order to meet those requirements. So all of our measures have a basis and a guideline, whether it's an ACR guideline or another organization's credible guideline. And we started out identifying kind of the core diseases that we were going to focus on in rheumatology. And from those guidelines, we have a work group that drafts measure concepts. We go through an expert voting panel, allow for public comment, then go through specification and measure testing. When we launched our measure testing and development program, we didn't have the Rise Registry, and so at that time we contracted with several practices and went through a chart abstraction data collection process. But since then, we have really used Rise as an engine for our measure testing, and Tracy will talk more about that. So next slide. So as we were going through the process of setting up our measure development program, NQF Guidance kind of evolved and changed and kind of became more comprehensive. So we actually had to go back and look at different parts of our process that we had developed that would meet some of the testing requirements. So we actually were able to use the expert panel voting to meet face validity testing requirements. And as I mentioned, we worked with sites to do front-end chart abstraction of data. So now I'm going to, in the next slide, I'll turn it over to Tracy to kind of talk through how we evolved that process and what we're doing now.
Thank you, Rachel. So as Rachel noted, over the past few years, we've been evolving our quality measure development and testing process and making tweaks as we go to take advantage of our role as a QCDR and the data that we have available through the Rise Registry to make our processes more efficient. I will say one big reason this has been possible is because of the partnerships we have in place through the Rise Registry. And you may note that the process that we have now is fairly similar to the process that Rachel outlined earlier, but we've been making those adjustments in an attempt to streamline our work and efforts and hopefully costs as well along the way. So, you know, as I noted, the process is pretty similar, starting still with a, guidelines development, and even some research results that inform measure drafting, We still have expert panel input, and obviously that is done throughout the process, so it's particularly helpful early on in our measure development. From there, we move to our measure specifications and go into registry implementation, and then use that implementation process as also a form of data collection to conduct our validity and reliability testing. Next slide. So in terms of the activities that we have going on now with our quality measure development, we were previously focused, we were previously heavily focused on measure development based on guidelines, and that still is obviously a huge source of our measure development and how we inform our measure development. But we've also taken to incorporating some research done with our registry data as well. And with the registry, we've also been able to incorporate scientific assessment of the data elements that we're looking to include in our quality measures as well. This is particularly helpful for anyone who wants to develop a risk adjustment strategy, because those elements can be key to the risk adjustments you incorporate into your measures. And while we're going through our measure development, if we identify any new elements that are needed that are not currently part of any of the measures that we have in the registry, we actually have an opportunity to contract with registry users for additional data collection and feasibility assessments on those data elements. And as mentioned, we implement our measures in the registry first, actually, to collect the data and then use the performance data to conduct our measure testing. Next slide. Obviously, there's some advantage to having a QCDR when you're working on quality measure development. As I noted, we have informed our measure development plans, not only with our guidelines, but some of the research we've been doing with the registry data. And two examples of that are our hydroxychloroquine dosing measure and our hepatitis B screening measure. So for our hydroxychloroquine dosing measure, there was new information that came out in the scientific community about safe dosing based on milligrams per kilogram. And some of our partners looked into the data in the registry data and saw that there was a wide variation in the dosing among patients on hydroxychloroquine, which is I'm sure we're all aware now, a very common drug among patients with rheumatoid arthritis and lupus. So there were even some dosage levels that were potentially dangerous for patients. So it became a very important area of focus for quality measure development so that people could track the dosage levels of their patients. And for hepatitis B screening, there's a requirement for some of the drugs that are commonly prescribed to rheumatic disease patients to screen for hepatitis prior to patients starting that drug. And we were seeing with the data that that just wasn't happening at a level that seemed appropriate. So again, we were able to use the registry data to inform our measure development. And then we are also, with our registry, we have direct access to our participants. And as we're discovering new elements that are needed or potentially needed for our quality measures, we can actually request their assistance with collecting that information and assessing the feasibility of that information being gathered during the course of clinical care and the importance of collecting that information, including it in quality measurement. So for example, we are currently in the process of developing some outcome measures, and we need to be able to risk adjust our outcome measures. But the data that we currently have access to was insufficient to make our expert panel comfortable with the adjustments that needed to be done to the measure. So we actually provided some financial incentives to some of our practices to conduct some additional data collection and provide some feedback on the feasibility and importance of those elements. and it has significantly pushed forward our outcome measure development. And of course, the part that is particularly of interest to this group is the ability to use our registry and the data collected through the registry with the performance scores collected as well to conduct our measure testing. And in particular, our main focus and shift from previous work has actually been focusing our reliability testing on signal to noise testing. And I have to also note, I am not a statistician. I have become familiar, I'm familiar with these concepts obviously through our quality measure development. For anyone who is not familiar with signal to noise testing, the idea essentially is that you're assessing the amount of variation in the performance scores on a measure that are due to error or noise versus the true performance variation or the signal that you want to come out of your measure. And while I know this, it was not me who actually conducted the analysis for this. We have an analytic partner that has been able to do that for us. The other major component of measure testing, as Mark touched on, was validity testing. And our main focus for validity testing has actually been score-level validity testing. And we're, for anyone who's not familiar with this concept, the idea of this is essentially to demonstrate that the trend of performance scores among a group matches the trend on a quote-unquote gold standard measure. So you essentially show correlation on the performance of the same group on your measure against the performance on a gold standard measure. So for example, a MIPS measure or an NQF endorsed measure. We're lucky that we have MIPS and NQF endorsed measures available in the rheumatology specialty that we can use as a gold standard measure for that. But for us, for example, one of the things that we're working on for our testing, our CMS testing for our QCDR measures, is actually building a suite of rheumatology specific measures that are MIPS measures that, and some of which are NQF endorsed. And we'll have average scores on those measures, and we'll use that as our gold standard, and then run the performance on each of our measures, our QCDR measures that we're testing against that gold standard, the average performance on that gold standard suite of MIPS and NQF endorsed measures. Next slide. So as I noted, and as Rachel noted as well, we have gone through the NQF process, and we have made updates to our process, our quality measure development and testing process based on NQF guidance. And through that, we have been able to do the appropriate measure testing with the data that we've gathered from the registry. And of course, throughout this, it's been extremely helpful for us to have an analytic partner in this. But I would point out that it is not exactly required to have direct access to the data or an analytic partner for this if you can get the appropriate reports from your QCDR vendor to run some of these analyses on your own. Of course, also as Mark noted, it is very helpful to have a partner that is experienced and familiar with all the various forms of measure testing and can provide some guidance along the way. But hopefully this at least helps you feel a little bit better about the requirements that are coming down from CMS about the testing, knowing that there are ways to try to mitigate some of the intensity that is required for quality measure development and testing. Next slide. So that covers the ACR's portion of this presentation, and we're definitely happy to have further conversations and answer more questions that you may have about our measure testing process and how we've incorporated NQF guidance into our testing plans and our plans moving forward to meet the CMS requirements for testing of our QCDR measures.
Thank you so much, Tracy and Rachel and Mark, for the great presentations. And apologies, Tracy, I mispronounced your name, so I thought I would mispronounce Rachel's last name, but I guess I got 2 for 1. So I sincerely apologize for that.
It's okay.
But,
I blame Scarlett.
We are going to be opening the conversation up for discussion. And, as Crystal noted, if you have any questions, please enter them in the chat, and we'll be happy to. I'll be happy to facilitate that discussion with our speakers. In the meantime, I'll take the liberty to ask all of you a question. I think one thing we've heard about, in particular, that people struggle with. I know when we do our own testing, we also can find it challenging to identify sites to help in testing. And I realize that that's only necessary to the extent that you're doing data element level testing. And I know ACR, you explained you're moving towards a score level testing, which is certainly something we've done. But you also mentioned involving sites in particular as you're, developing new measures that may require additional data collection of elements that don't already exist in the registry. So I wonder if you could, and Mark, I didn't know exactly how. I know you described that it's an interface with the part of the work you already are doing in your abstraction methods. But I wondered if you could talk a little bit about any of that interaction with or need to try to identify sites, and any things that you found particularly helpful to get them to work with you on identifying and helping, and to the extent that you need them to.
So Rachel and Tracy, I think this is probably more relevant to what you've described. I'll defer to the two of you to take this on, and I may comment after.
Okay. Yes, this is Tracy. Yeah, I can take that one. So I would note that by the nature of our registry, we collect quite a large amount of information from EHR systems. So we are starting off with a pretty significant base of data to begin with, and it's not always just data that's specific to our quality measures. However, we've encountered issues when we're looking for information that may be captured in the clinical notes. And while we do have processes to get that information, if that information is not tied to a quality measure, we may not have the ability to really do any successful analyses on that information. So what we ended up doing was we were lucky. We had some funding available for our measure development, and we reached out to some of our Rise practices that had a diverse set of characteristics, so different sizes, different patient populations, different geographic locations, even different EHR systems. And we provided some financial incentives, so a few $1,000s, to agree to share some additional information on their patients in a way that, in a structured format, that we could actually link back to those patient records and then run some analyses. And this was specifically for our risk adjustment for our outcome measures. Excuse me. So that information was used to go back and determine their potential impact on patient outcomes, which was something we had already been collecting through the registry. So it was a less common bit of information that would normally be easily accessible in patient records. So it pretty much necessitated the need for us to do that. But where available, we try to not bug our providers more than needed, essentially.
Makes sense. Thank you for that. Mark, anything to add or?
Well, I would only add, Sam, that from the STS perspective, again, we have pretty much all of the data that we need will have been submitted via the registry. The only instance that I mentioned where we need to call upon cooperation of sites, of practice sites, is in doing the annual audit that I described, where, again, we have a contractor that we work with to do that, and they audit about 10% of our sites, of our surgical practices. I don't know, again, I'm not involved in that directly, so I don't know what challenges they may encounter in securing the cooperation and the participation of those sites. I'm not aware of that being a particularly challenging issue for us. So beyond that, I think what Tracy has described is probably more relevant to many of the participants on this call.
Okay, great. Thank you. Anybody else have any questions? The chat box is open.
Sam, there is a question in the chat box, and I can read it aloud.
Okay. Maybe I can't see them, Crystal. Sorry.
Oh. So ACR discussed their registry was integrated with the EHR, and that was a starting point to make sure data elements were available for testing. What EHR vendors are they partnered? Is there variation of data feasibility based on EHR vendors? Are there any checkbox data elements used in the measure calculation, or are the data elements all structured data used in care delivery? And that was from Sharon eBay.
So Tracy, do you want me to start and then you can fill in?
Yes, yeah. I was just about to suggest the same thing.
So our technology partner for our registry is SIG-MD, and they work, they're able to extract data from a number of EHRs. And I think, Tracy, correct me if I'm wrong, but we have, is it like more than 50 different EHRs connected to Rise?
It's right around there.
Yeah, and so in terms of, there is some variation in data, but we kind of work as part of our QA process to map to the data concepts we need according to the specific EHR. And there was another question about, was there another question?
One second. So the other questions, what EHR vendors are they partnered, and is there variation of data feasibility based on these EHR vendors?
Yes. So it's pretty much, we can connect to any EHR. We've been pretty successful across the board. And I think there was a question about structured versus unstructured data, and our measures do have both structured and unstructured data elements incorporated. Sometimes we're able to pull the unstructured data into a more structured format for our measure testing, but in some cases, like Tracy mentioned, that's where we do need to go back out to practices and do some additional data collection.
And lastly, are there any checkbox data elements used in the measure calculation, or are the data elements all structured data used in care delivery?
I don't believe there are any checkbox data elements. Tracy, is that accurate?
Yeah, off the top of my head, I can't think of anything that is just essentially a yes or no checkbox. In terms of the structured data elements, the vast majority of the data that we're working with is something that is going to be captured in, medication information or lab information or things like that. And obviously, information, the way the information is structured from the EHR varies a bit from EHR to EHR. But as Rachel mentioned, one of our processes for onboarding involves reviewing that information, how that information is structured, and pulling that into a format that is consistent across all of Rise practices.
Thanks. It looks like we have a few more questions in the chat window. Does your feasibility testing include assessments across multiple EHR vendors?
Yes. So when we look at the feasibility kind of scorecard, we try to kind of diversify in terms of both practice size, geography, and EHR vendor.
And our next question is from Debbie Gibson. Can you please remind us of the monetary incentive provided to clinicians for extra data collection?
Tracy, do you want to take that?
I think I might need a little more clarification, as in, like, how much did we offer, or what was the process that we followed in doing that?
How much offered?
We offered each of the practices a few $1,000s, but it was before we, let me put it this way, before we settled on how much we offered to the practices, we compiled the data that we were interested in collecting and had our expert panel discuss just how much data that was and how much effort would be required to go into collecting that data, and it was fairly extensive. So it would be one of those things that is a very request by request based incentive for our practices.
Okay, do we have any additional questions? Please type them in the chat box.
Crystal, thanks for, since I couldn't see the questions, I can see them now. I can take back control of the conversation. I think that there are no other questions coming in. I can see, oh, we just got one. What is the general size of the data set used for testing? Can any of our participants comment on that question? I think you might need more information to answer it, but I'll defer to you.
Yeah, I think more information would probably be helpful.
Yeah, do you mean, I think, Debbie, do you mean in terms of, like, for an SNR analysis, do you mean like the number of physicians that are part of the analysis? Do you mean the, okay, that's what she means, number of clinicians. Can you guys share your experiences? Do you recall how many clinicians are usually included in the analyses you do?
Well, so this is Mark. I'll just start on behalf of STS. And I don't think I said anything about this during my presentation, but STS requires that the participants in our registry, this applies not only to our adult cardiac registry, but to our congenital and our general thoracic as well. Surgeons and their staff are required to submit data on every single surgery. And so the analyses that we do, again, and we do them for our NQF submissions and then use them for CMS and MIPS, the analyses that we do are based on all of the participants that we have in a particular period. So we don't have a threshold for how many are adequate, we simply take all of the data that we have in the registry. I can tell you that for adult cardiac measures, in a specific harvest period and a particular period in which data has been submitted, it generally is anywhere from 900 to 1,000 participating practices. But again, we don't have a threshold for what is adequate. We simply, I shouldn't say simply, but we use all the data that has been submitted from all of the surgical practices that are participating in a given time period.
Thanks, Mark. And from ACR, do you have a sense of the size of number of clinicians? And Debbie also has to follow up about patient volumes, if you have a sense of that.
Yeah, our registry, I mean, rheumatology as a specialty is a little smaller. So we take the same approach in terms of when we're doing measure testing in Rise, we test it across all the rheumatologists in Rise who we have data for that measure. So it usually ends up being, you know, a good percentage of the total 1,000 or so providers. I do know when we contracted with practices in our initial round before we used Rise as measure testing, we worked with 3 different practices, and so it was a much smaller number. So we had maybe like 15 total providers participating, and we had them enter charts, and we actually worked with PCPI at that time to make sure that we had sufficient amount of abstraction to get the reliability that we needed in order to submit for NQF. So if you don't have a big database, then you do have to kind of look more at your volume of providers.
Thank you. I think that was helpful. So I'm going to move us forward to wrapping up now. I really appreciate the good insights that you all have shared and your time today, and the participants for joining the discussion. Crystal, oh yeah, I was going to say, if we could go to the next slide. We are going to wrap up our testing webinar series in May with a presentation about specifically testing for electronic clinical quality measures, since there are some unique requirements for that particular designation within the NQF requirements. And then next week, we have on April 28th, the QCDR conference, which is going to be conducted virtually. So please sign up for that if you have not already. Next slide. And then just a few reminders just for your information. The information will be, the slides and the recording will be posted at our website. We'll send you updates by email. And if you have any questions, you know, there's 2 generic email boxes that we have to answer any questions you might have, or you could always reach out to me or any of your PCPI colleagues with any questions that might have come up from this conversation. Thank you, everybody, for your time. This was a great presentation. We really appreciate it. And stay safe. Be well. Goodbye.
Thank you. Bye-bye.